afternoon everyone. Today's topic of discussion is applied anatomy of heart with dissection. In this we are going to see overview of heart, anatomy of heart, dissection of heart and applied anatomy of heart. Overview of heart. Heart is a conical hollow muscular organ measuring 12 by 9 by 6 cm in size, weighing 0.45% of body weight. In female, it's 250 gram. In range, it's 170 to 350 gram. And in male, it's a 310 gram. In range, it's a 230 to 400 gram. Heart is situated at middle mediastinum. It has 4 chambers, right and left atria and right and left ventricle, separated by atrioventricular groove. Apex is formed entirely by left ventricle and base is formed by left atrium and small part of right atrium. Relations of the heart: superiorly aorta and superior vena cava, pulmonary artery and pulmonary vein; inferiorly by the diaphragm, anteriorly ribs and intercostal muscles, posteriorly esophagus, trachea, descending aorta, inferior vena cava and thoracic vertebrae, laterally by the lungs. Borders of the heart: upper border, which is slightly oblique, mainly formed by left atrium and right atrium. Right border, formed by right atrium, extend from superior vena cava to inferior vena cava, and inferior border is formed by right ventricle and near the apex is formed by left ventricle. Left border, it's oblique and curved, mainly formed by left ventricle and partly by the left auricle. Coverings of the heart: pericardium. It is a fibrocellous sac, encloses the heart and root of the great vessels. It contains fibrous and serous pericardium. On cross section, the combined thickness is 1 to 2 mm. Fibrous pericardium is a compact and collagenous, while serous pericardium, it has outer parietal and inner visceral layer. Pericardial space and fluid. Pericardial cavity is a space between parietal and visceral layer of the serous pericardium, contain approximately 15 to 20 ml of pericardial fluid. Pericardial reflections. These are the reflections of serosal layer arranged in two tubes, arterial tube and venous tube. Arterial tube encloses the aorta and pulmonary trunk, while venous tube encloses the vena cava and 4 pulmonary veins. The passage between arterial tube and venous tube is known as a transverse sinus. Transverse pericardial sinus lies anterior to superior vena cava and posterior to ascending aorta and pulmonary trunk, while oblique sinus bounded anteriorly by left atrium and posteriorly by parietal pericardium. Layers of the heart valve. It consists of 3 layers: outer epicardium, middle myocardium and inner lining of endocardium. External examination of the heart. Now, before doing dissection of the heart, it is very important to do external examination of the heart. Features to be noted in external examination of the heart are orientation, cardiac size, epicardial surface, atrial appendages, coronary artery dissection. Orientation. The heart has to be oriented in normal anatomical position. Axis of ventricle is oriented laterally to the left from base to apex. Apex is situated at the left and formed by the left ventricle. External examination of the heart. Color. If the color is a grey on the external surface of the heart, it's suggestive of old infarct. If mottled and hemorrhagic, it may be acute infarct and ruptured. Pale is seen in anemia. Also, see cyanosis or blue discoloration of the heart, edema, congenital anomalies and petechial hemorrhages. Petechial hemorrhages are seen in thrombocytopenia, sudden hypoxia, blunt trauma, septicemia and metastatic deposition are seen in mediastinal tumor and carcinoma of colon. Cardiac size. Heart may be normal, small or enlarged. The surface anatomy of LAD offer an excellent guide to the position of interventricular septum. In moderate cardiomegaly, due to marked enlargement of right ventricle, apex is slightly rounded and formed by right ventricle. In marked hypertrophy of left ventricle, there is a rightward shift of LAD. Epicardial surface. Normally, epicardial surface is a smooth, shiny and transparent. On epicardial surface, inspect for thickening, increase in adipose tissue, increase in fluid and exudate. If infective pericardial pathology is suspected, then the pericardial surface is a seed with a heated spatula and incised with sterile scalpel blade, so that necessary material for culture is collected with a swab. Alternatively, the material is collected by sterile needle and syringe. Surface of the heart, and we have anterior and posterior surfaces of the heart. On anterior surface, we can see vessels include ascending aorta and pulmonary trunk, right atrial appendages, and mainly right ventricle and left ventricle. On posterior surface of the heart, we can see superior vena cava, inferior vena cava, pulmonary veins, left atrium and right atrium, mainly left ventricle and right ventricle. Also, we can see coronary sinus, which is situated longitudinally in posterior atrioventricular sulcus. Atrial appendages. The right atrial appendages is large, triangulated with broad base, and it is pectinated. Left atrial appendage is crenellated and like a crooked little finger. Coronary artery anatomy and dissection. Atrioventricular sulcus, also known as a coronary sulcus. Atrioventricular sulcus, it is divided into anterior and posterior. Further, anterior atrioventricular sulcus is divided into right and left. Right anterior atrioventricular sulcus lodges the right coronary artery, and left anterior atrioventricular sulcus lodges the left circumflex branch of left coronary artery. Anterior interventricular sulcus contains left anterior descending artery, and posterior interventricular sulcus contains posterior interventricular artery. We will see the course of coronary arteries. The right coronary artery originates from anterior aortic sinus, and further it emerges in between pulmonary trunk and right auricle. It courses in right anterior atrioventricular sulcus and descend downward to the junction of right border of the heart and inferior border of the heart. It winds around the inferior border of the heart to reach the diaphragmatic surface. Further, on posterior surface, it forms anastomosis with left coronary artery. Left coronary artery originates from left posterior aortic sinus. It emerges with pulmonary trunk and left auricle. It courses in anterior interventricular sulcus and gives branch as a left anterior descending artery. After giving LAD as a branch, it courses in left anterior atrioventricular sulcus and winds around the left border of the heart to reach the posterior surface of the heart. In posterior surface of the heart, it gives branch. It forms anastomosis with right coronary artery. Coronary artery dissection. We do coronary artery dissection by serial cross sections at the interval of 0.5 cm. The degree of stenosis to be noted during coronary artery dissection. It may be less than 50%, more than 50% to 75%, and more than 75%. Atheroma, it is a major cause of stenosis. Identification of type of atheroma by color and texture. Atheromatic plaque can be fibrous, fibrofatty, and fatty. Complications to be noted during dissection of coronary arteries are calcification, thrombosis, and intraplaque hemorrhages. Veins of the heart. The coronary sinus, it is the largest vein of the heart, 3 cm long, situated in left posterior coronary sulcus, ends by opening in posterior wall of right atrium. It receives following tributaries: great cardiac vein, middle cardiac vein, small cardiac veins, posterior vein of left ventricle, oblique vein of left atrium of Marshall, and right marginal vein. The anterior cardiac vein and vena cordis minimi open into the right atrium. Dissection methods of the heart. There are various methods of the dissection of the heart. Most commonly performed is inflow and outflow method, also known as a Virchow's method, short axis method, also known as a braid slice method, 4-chamber method or long axis method, base of heart method, window method, unrolling method, and partition method. Inflow-outflow method of the heart dissection. First, 3 incisions which are given each on right and left side of the heart. On right side, first cut is given along the probe which we will pass from inferior vena cava to superior vena cava. After giving cut, inspect for tricuspid valve which usually admit 3 fingers. Second cut is given along the right border from right atrium to right ventricle. In this, posterior tricuspid leaflet is cut. Third cut is given along the outflow tract into main pulmonary artery. The left side, same 3 incisions are the given also on left side. First incision through 2 superior pulmonary veins. After giving incision, inspect for mitral valve, which usually admit the 2 fingers. Second incision given along the left border of the heart to the apex of the left ventricle. Third incision given through anterior mitral leaflet and wall of left atrium and it open into the ascending aorta. After opening of the heart, we will do internal examination of the heart. First, right atrium. Right atrium is divided into smooth posterior part and rough anterior part. Smooth posterior part gives opening to the superior vena cava, inferior vena cava, coronary sinus, vena cordis minimi. And the rough anterior part present as a series of transverse muscular ridges called as a musculi pectinati. Interatrial septum present as a fossa ovalis or saucer-shaped depression. Annulus ovalis or limbus fossa ovalis is a prominent margin of fossa ovalis. Triangle of Koch. Dotted line here, the dotted line indicate the triangle of Koch demarcated by orifice of the coronary sinus and its wall, the Thebesian wall. Anterior extension of eustachian wall, the tendon of Todaro to the central fibrous body and the septal tricuspid leaflet. Left atrium, it receives oxygenated blood from lungs through 4 pulmonary veins. Internally, left atrium is a smooth wall. Valves of the heart. The tricuspid valve, it consists of 3 cusps, anterior, posterior and septal leaflet. The cusps are formed by fold of endocardium and some connective tissue. The cusp attached to fibrous ring of the heart and other end is attached to the papillary muscles by chordae tendineae. Mitral valve, it consists of 2 cusps, anterior and posterior. It guards left and atrioventricular or mitral orifice. Pulmonary valve, it guards the pulmonary orifice. It has a 3 semilunar cusps, 1 anterior and 2 cusps posterior. There are no chordae tendineae or papillary muscles attached to this pulmonary valve. Aortic valve, the valve arranged as an anterior and posterior. It has a 3 cusps, 2 anterior and 1 posterior. The right coronary artery originates from anterior aortic sinus and the left coronary artery originates from left posterior aortic sinus, and there is a non-coronary cusp from which no coronary artery arises. Ventricles are the right and left ventricle situated. The right ventricle, this is a coarsely trabeculated. The cavity of right ventricle is slightly crescentric due to bulge of interventricular septum. The thickness of the right ventricle is a 0.25 to 0.5 cm measured 1 to 2 cm below the mitral annulus. The left ventricle is a finely trabeculated. Thickness is a 1 to 1.5 cm and the ventricular septum thickness is a 1.2 to 1.6 cm. There are other method of dissection of the heart, also known as a short axis method of the cardiac dissection or braid slice method. It is a method of a choice of dissection in ischemic heart diseases. By the short axis method or braid slice method, these slices exposes the large area of myocardium. The steps, first, flat diaphragmatic aspect of the heart is placed on a paper towel. With the help of long knife, 1 to 1.5 cm thick cuts are made parallel to atrioventricular groove. Each slice is a view from apex toward the base. The basal third of the ventricle is attached to the atria and open according to the inflow and outflow method of the heart dissection. Another method is a 4-chamber method of the heart dissection. With the help of a long knife, begin the cut from cardiac apex which extends through acute margin of right ventricle, obtuse margin of left ventricle and ventricular septum. Extend cut through mitral and tricuspid valve through atria. This will divide heart into 2 pieces, will show all 4 chambers, upper right and left atria and lower right and left ventricle. Upper half is open along the outflow tract. Four-chamber method of heart dissection is useful in dilated cardiomyopathy. Another method is a long axis method. Before making the cut, the plane is demarcated with three straight pins. First at the cardiac apex, second in right aortic sinus, and third near the mitral valve annulus. Cut heart along the plane from apex toward the base, which passing through mitral and aortic valve. Methods of the dissection and its use. Base of heart method is useful in prominent valvular disease. Window method for dry cardiac museum specimen. Partition method for assessment of ventricular hypertrophy. Unrolling method done in research study. Applied anatomy of heart. First, atherosclerosis. It is an arterial wall thickening. Fatty streaks are seen, which are a lipid-filled foamy macrophages. First, fatty streak begin as a multiple flat yellow spot which coalesces into elongated streaks. Atherosclerotic plaque are intimal thickening and lipid accumulation which together forms plaque. Plaque are white yellow and roaches on the lumen of the artery. Atherosclerosis can be mild or severe. Mild atherosclerosis composed of fibrous plaque and severe atherosclerotic lesions show ulcerated plaque. Normally, the pericardial fluid is a clear, pale yellow and less than 50 ml. In pericardial diseases, if there is a excessive fluid, it can be transudative and exudative. Transudative fluid seen in pericardial effusion. Frank blood, if present, seen in hemopericardium, and a purulent seen in pericarditis. Myocarditis, it is an infectious agent or inflammatory process causes the myocardial injury. Causes can be viral or bacterial or any infectious agent, most commonly Coxsackie virus. Grossly, the heart appears as a normal or dilated. In advanced stage, myocardium is a flabby, mottled with pale and hemorrhagic areas. Microscopically, in myocardium, we can see edema, interstitial inflammatory infiltrate and myocyte injury. Diffuse lymphocytic infiltrate is the most common seen in myocarditis. Congestive cardiac failure. In this, heart is unable to pump the blood at a sufficient rate to meet the metabolic demands of the tissue. Pressure or volume overload causes myocyte to increase in size, which lead to hypertrophy of heart. The left ventricular hypertrophy or pressure hypertrophy due to left ventricular outflow obstruction. In this image, we can see the left ventricular hypertrophy with and without dilatation. We can say left ventricular hypertrophy if left ventricular wall thickness is more than 1.5 cm and right ventricular wall thickness is more than 0.5 cm. In this microscopic image, we can see the increasing cell size and nuclear size of hypertrophied myocyte. We can see here a box-shaped nucleus which is seen in hypertrophy. Ischemic heart disease. In this, myocardial ischemia, it's an imbalance between myocardial oxygen supply and cardiac demand of oxygenated blood. We need to do examination of a myocardium in ischemic heart diseases by bread loafing of the heart. Location of the infarct and extent of the infarct can be basal third, middle third and apical third. Distribution of infarct can be subendocardial or transmural. Subendocardial if it involves less than half thickness of the wall and transmural if involves more than half thickness of the wall. In this figure, we can see acute transmural infarction which affecting posterior wall and posterior half of interventricular septum. The infarct is a yellow with zone of hyperemia. Early morphological recognition of acute myocardial infarction with the help of TTC test. It's known as a triphenine tetrazolium chloride test. The non-infarcted myocardium where LDH activity preserved shows brick red color, and in myocardial infarction where LDH is leaked out through dead cell appear as an unstained pale zone. Microscopic demonstration of acute EMI with the help of nitro-blue tetrazolium test. It is a positive from 3 hours after the onset in non-infarcted myocardium where LDH activity is preserved showing purple color, and where in myocardial infarction where LDH is leaked out through dead cell appear as a unstained pale zone. In this, the slice we see circumferential subendocardial infarct which is a pale in color. This is a microscopic picture in myocardial infarction. This is a 1-day-old infarct showing cognitive necrosis and waviness of the fibers, wide spaces between the fibers and edema fluid with scattered neutrophils. This is a 3 to 4-day-old infarct picture showing dense neutrophilic infiltration. This is a 7 to 10 days old where removal of necrotic myocytes by the phagocytosis. This microscopic picture showing characteristics loose collagens and abundant capillaries which are granulation tissues. This is a healed myocardial infarct in which necrotic tissue has been replaced by the dense collagenous scar. Complications of myocardial infarction, it can be anterior myocardial rupture, rupture of ventricular septum, complete rupture of necrotic papillary muscles and fibrinous pericarditis. Calcific aortic stenosis, recurrent chronic injury due to hyperlipidemia or hypertension and inflammation which causes mechanical stress on the valve which leads to valvular degeneration. Deposition of hydroxyapatite, which is a calcium salt, on gross appeared as a calcified mass protrude through outflow surface into sinus of Valsalva, present as a which prevent the cuspal opening. Microscopically, calcified process begin in the valvular fibrosa and inflammation and metastatic bone may be seen. Rheumatic heart diseases, these are the fibrotic valvular disease, particularly involve mitral valve. On gross, small vegetation seen along the line of closure of mitral leaflet. Fish mouth appearance of mitral valve due to mitral stenosis with diffuse fibrous thickening, commissural fusion and shortening and thickening and fusion of chordae tendineae. Microscopically, focal inflammatory lesions are the seen. Ashcombe body, these are the characteristics of rheumatic heart disease. These are the granulomatous lesion, consist of foci of T lymphocyte, occasional plasma cells and plump activated macrophages called Short cells. These are the short caterpillar cells. Infective endocarditis, microbial infection of the heart wall or mural endocardium that lead to formation of vegetation associated with destruction of cardiac tissue. Acute cause may be staphylococcus or subacute streptococci. Vegetation or wall, these are a large, friable, bulky, destructive lesion containing fibrin and inflammatory cells and microorganisms. Comparison of various vegetative endocarditis. In rheumatic heart diseases, it marked by appearance of small warty inflammatory vegetations along the line of wall closure which later gave fish mouth appearance. This is the infective endocarditis valve characterized by large irregular destructive masses, and in non-bacterial thrombotic endocarditis, they are small to medium sized, bland, non-destructive vegetation at the line of valve closure. Liebman sac endocarditis is characterized by small to medium sized inflammatory vegetation attached on either side of wall leaflet. These are my references. Thank you.